My name is Nosley, and I'm proud to represent part of the Stanford sleep surgery team here today. I'd like to spend the next few minutes talking about how age and gender can affect the outcomes of maxillomandibular advancement surgery for patients with obstructive sleep apnea. I have no disclosures, however, I would like to thank our wonderful Stanford sleep surgery team and faculty mentors Dr. Stanley Leo and Alan Huang, without whom this would not be possible. Today, the literature reports the prevalence of obstructive sleep apnea, otherwise known as OSA, to be 24% in males and 9% in females. This does not surprise many of us, as OSA by nature has been described as a male-dominant disorder for decades. However, it is important to understand that there are significant gender disparities in the diagnosis of OSA. Diagnosis in females is oftentimes missed, as the disease onset and presentation are slightly different when compared to their male counterparts. In fact, the literature reports an underdiagnosis of up to 90% in females. When we reflect on why, this makes sense. The physiology is inherently different, and thus so is the disease process. Known disparities in diagnosis of OSA have raised concern for possible disparities in surgical treatment options presented to male versus female patients. So we have to ask ourselves, where does gender fit into the sleep surgery algorithm? This is a question that was raised by one of my colleagues in 2020. And actually, she found that non-gender specific AHI can handicap the surgeon from offering the full range of available procedures to women with OSA. Her work leads us to push further and wonder if there's a difference in surgical outcomes between male and females. The remainder of this presentation will focus on our findings with regards to surgical outcome. From the preliminary data, we can conclude that there is in fact a correlation between gender, age, and surgical outcome. Postmenopausal females have a lower surgical success rate after MMA when compared to their male counterparts when matched for age and BMI. There is no significant difference in subjective surgical outcomes such as the Epworth Sleepiness Scale when comparing the male and female populations undergoing MMA. When we take a step back to understand why postmenopausal females respond less favorably, we have to look back at the basics. By definition, menopause results in decreased anabolic hormones, notably estrogen, which plays a critical role in various physiological mechanisms that are important in surgical success. First, decreased estrogen results in decreased muscle tone, also known as sarcopenia. Why is this important? Well, we have to remember that the upper airway passage is a collapsible tube formed of muscles that are attached to the facial skeleton. The purpose of MMA is to reposition the skeleton into the proper position so that the soft tissue follows and long-term muscle remodeling may occur. With reduced estrogen load and decreased muscle tone in the postmenopausal female patient, this remodeling is limited, thus reducing the efficacy and surgical outcomes for this cohort. Additionally, decreased bone quality can lead to postoperative complications and compromised healing. Finally, weight gain that is often accompanied by menopause increases the burden of disease and enables further OSA progression in this cohort. While this is a preliminary study, it reveals that surgical treatment modalities must address patient age and gender as risk factors. Precision medicine requires an appreciation of gender disparities in diagnosis and surgical treatment. The recognized limitations of the study, of course, are of the female sample size, particularly the postmenopausal female sample size. Thus, a larger and more comprehensive study is required to better understand these trends across all surgical modalities for the treatment of obstructive sleep apnea. I'd like to thank you for your attention and encourage you to reach out with any questions.